Yeah, I think this is, you know, we assembled a committee initially to come together to address these questions surrounding how to approach the care of those patients who are admitted to the hospital with either established diagnosis of sleep apnea or a suspected diagnosis of sleep apnea, recognizing there really is no guidance that's out there so far. And the fact that there are some data to support that um, individuals with established sleep apnea um, or high risk are at increased risk for um, worse clinical outcomes, readmissions to the hospital, and there's some data to show that having sleep apnea can increase your length of stay in the hospital. Some data to support that it can be associated with increased costs as well. So those were the reasons why, given there's really no guidance, and there hadn't been sort of a systematic appraisal of uh, the evidence that we have so far to provide that guidance, was why we had a diverse group of individuals from neurology, from pulmonary, from hospital medicine, um, uh, you know, it's just kind of come together um, to try to synthesize the data that we have so far. And then we had methodologists that really had expertise in terms of how to um, effectively bring that data together to come up with some recommendations. I think, this was basically, a lot of these are conditional recommendations and based upon, again, the evidence. When we first embarked on this initiative, we weren't sure that we would have enough evidence to even make any recommendations. It turns out that there was enough direct evidence and some even indirect evidence where we could, develop these recommendations. And one, as you said, was to that we should be conducting in-hospital screening for sleep apnea as part of the evaluation and management of the medically hospitalized adult. We don't provide specific guidance in terms of how to screen. There are many studies that were done. A lot of them, used subjective assessments to screen for obstructive sleep apnea. Some used objective measures like high resolution pulse oximetry to really get a sense of, oxygen desaturations patterning that makes you really suspect sleep apnea as part of a screening process. So, we just kind of again synthesized those data, um, and uh, recognizing again that, like you said, there may be limited bandwidth to do this, resources to do this, needing kind of processes in place to do this, either through the electronic medical record or otherwise. Um, the implementation of this recommendation is going to be kind of subject to the resources available at the respective institution. And we kind of thought about this, in terms of, hey, this is what the data are telling us. And this is the first guideline. It's kind of paving the way in terms of making the recommendation. And then, as this goes along, hopefully we can have processes in place that can also be recommended to actually implementing this. Yeah, I think it's basically, these are the conditional recommendations, recognizing that, the data are there. There's limitations to the data. There's, risk of bias with some of the data that was looked at. But there was enough there for us to make a conditional recommendation. So with that in mind, then the feasibility of whether you can implement the recommendation, the the clinician's assessment of the situation. So their lens of expertise in combined with the recommendation, the conditional recommendation should be um, taken into consideration. If they have a patient, again, who's high risk, meaning they have cardiopulmonary disease, neurologic disease, and they are assessing them, and they have not been previously diagnosed with sleep apnea, and they think they're at high risk for sleep apnea, and that treating that sleep apnea may help that condition. Then your preference may be actually to be more proactive and screen and diagnose and treat that patient for their sleep apnea. If the patient's, then the patient's preference comes into play as well. So if the patient really is someone they're kind of in the throes of dealing with, say, a heart failure or COPD exacerbation, and may not be receptive to, considering this diagnosis of sleep apnea because there's too much else going on, then that's a situation where you may want to discuss it with the patient and then arrange for an outpatient sort of assessment. So there will be the need to integrate the conditional recommendation with the clinical status of the patient and the preference of the patient. I mean, I think I wish I could give more guidance on this front. You're right, telehealth has been used in that kind of post-discharge model to allow because you may, for instance, diagnose somebody in the inpatient setting, try to get them started on treatment, and you want to make sure that there's then follow-up of that to make sure they're adhering to positive airway pressure, make sure you're troubleshooting any issues. Telehealth may allow that to occur more seamlessly than, scheduling an in-person visit. So there's opportunity, I think, to examine that a little more closely and as a future direction, have clinical trials designed to look at that more carefully to see if there's utility to that approach. And even just, inpatient sleep medicine consult models, can it be nursing led, APP led? What are the processes that need to be in place for an inpatient sleep medicine consultation? If you don't have board certified sleep medicine specialists, what other expertise can be leveraged to have an inpatient sleep medicine consultation? So I don't have any specifics in terms of what I would recommend, just because I don't think we have the data to really back that up. But there was enough to say that having an inpatient sleep medicine consultation service actually increases the likelihood of a sleep study-based diagnosis of sleep apnea. So that is in large part why it was a conditional recommendation.